Thank you. It's a pleasure to be here. I appreciate following such excellent speakers and knowledgeable folks. This talk is will be a little bit conceptual, and I think the notion was to try and pull some of that together and raise some questions for you all in terms of that. So I did have some ARS questions. Maybe they put them at the end. I couldn't resist this title, Are These Drugs for Real? I mean, we are in Washington, D.C., and so it raised a question about fake news and real news. And so then because I thought a lot about this title, I said, well, they must be talking about fake drugs and real drugs, and that didn't really make sense to me either. And I think what we're really talking about is data and how that affects how we practice when we sit across from a patient. And I had to put single quotes around fake data because I don't think there's such a thing in any of the kind of sterling studies we just saw. But there are questions about real data, and ultimately, how does that translate into the real world, which is guidelines and how they influence how we treat patients. And I think we live in very complex times, and physicians are very, very busy, and I think guidelines are quite important across the spectrum for physicians, for payers, and so this issue can't be ignored. So here we go, audience response. So I'm curious to know this from all of you. In the past month, the number of prescriptions you've written for an anti-diabetic medication, 0, 1 to 10, 11 to 20, or more than 20. And there's a tremendous amount of interest in this issue because, as I'll touch upon, there's been a great interest from organizations like the ACC to have cardiologists more actively involved with treatment. And so one of the questions is the kind of data we've just seen, is that going to change that? So, often in these sessions we're preaching to the converted, but I would say that even having 50% of you writing a script for an anti-diabetic medicine is impressive. And so let's just explore that. The most significant reason why you haven't prescribed or even titrated anti-diabetic meds at all, or why you haven't done it more. Your uncertainty about how much you know about diabetes, don't feel comfortable with it. Concerns about infringing on the PCP or internist role, and is that one of the things we hear is that maybe that's going to affect referral sources. Concerns over who's going to follow this up. I'm going to start a drug, but I really don't have the infrastructure. I don't have a diabetes certified educator or nurse, so who's going to follow that up? And concerns over liability, like hypoglycemia, a patient doesn't do well, or some other side effect. Or just, frankly, I'm too busy. I'm too busy managing cardiology. Now you want me to manage diabetes. I'm just not going to be able to do that. So your top input on this in terms of motivators, I realize just one, it's probably many of these at work. And obviously, this is not a randomized control database here, but we're across the spectrum of 20% uncertain about the diabetes part. I think an honest answer, 30% about the internists and what they're going to think, who's following it up. Not about liability. Those must be people who don't live in the Northeast. And already too busy, I think, is a valid concern. So I think there's a lot at work here, and really very exciting times we live in to be having to wrestle with these issues. So in translating these trials into clinical practice, one of the questions, of course, is where do we stand now in terms of guidelines and the integration of this new data. I'll talk about that. I think it is a new era, and this new data and the concepts that come with it raise lots of interesting questions for us to wrestle with. Around the fact that we have an anti-diabetic agent, that's what it was developed for, that has cardiovascular benefit. It raises questions about cost versus benefit. We just had Dr. Pfeffer raise a question about why is metformin first line, and maybe it's a factor around that, or it's part of it. And then questions around specific drug data versus class effect, as we've heard allusions to. And then ultimately, I'll finish up with talking about translating trials into clinical practice. So the first point I would make is this idea about guidelines. And I think we have to keep in mind that we have different writers of guidelines, and that now we have to be thinking more about who's reading those guidelines, and it may not be the same in terms of that approach. So we have the ADA, the European Diabetes Group, ACE as clinical endocrinologists, Canadian Diabetes Association was alluded to in the ESC. But the readers differ. The readers differ of those guidelines. And obviously, primary care physicians are critically important. We will not change cardiovascular complications among people with diabetes without participation by internists and family practice physicians. There are not enough endocrinologists. And I think waiting for the traditional trickle down of that someday those folks will come to learn from the endocrinologists how they're managing state-of-the-art diabetes management will take too long. And then the third group here is cardiologists, and most of my comments are oriented towards the cardiologists. So the Canadian guidelines emphasize individualizing treatment and metformin first, and then consideration about EMPA or LIRA based on the data. Very recently, in 2015, the ADA and the EASD were also metformin first, but then said pick among the other 6. There's no preference there. That's been updated just in 2017, 2 years later, and significantly after the trials came out, after metformin, consider these 2 drugs if the A1C control is not optimal and if they have atherosclerotic cardiovascular disease. Very interesting question there. Here you have evidence for benefit, and you've gotten there through drugs that don't have cardiovascular benefit, but there's nothing in here about swap out the drugs. It's if you're not at goal. And that's the kind of challenge I think this data presents to us of continuing management, let's say with metformin and a sulfonylurea, with there being no evidence for as clear a benefit as you see here, but the patient's A1C is adequate. Is that really modern therapy of the ultimate benefit for a patient? The ACE 2015 practice guidelines already were referring to EMPA and LIRA, and I think because of that, they don't feel that there's necessarily a need to change after this trial data, but there may be an update. And then I think very importantly, as alluded to before, the ESC has heart failure management and type 2 diabetes about incorporating EMPA. So we saw this before. Here's the Canadian guidelines. I just want to emphasize this as well, this idea that an SGLT2 inhibitor might be considered. And I think of value here are some of these other points that are raised around this consideration in terms of risk of hypoglycemia being fairly rare. You have the weight loss benefit. There's a cardiovascular outcome benefit. So this really incorporates this idea of the individualizing to the patient's characteristic, and that you may want to consider that in a patient with high cardiovascular risk with prior cardiovascular disease in terms of choice of therapies. So this is a little deeper dive into that algorithm, and I just want to emphasize here this choice and these factors, and the fact that this can be very important for the cardiologist who's thinking about treatment to have input about safety questions and how to tailor that. And as Silvio touched upon, we now have the guidelines from 2017 saying that if you're suboptimally controlled, not a swap out, and diabetes and established ASCVD, that you can consider these drugs given this benefit. And here's the algorithm synopsis of that as well. So I think this is incredibly important. Here we have the European Society of Cardiology talking about the use of an anti-diabetic drug in a patient with heart failure. And I think this is pointing to us directions we need to go here around thinking about this, because it is showing up with the 2A class of evidence at level B. And it's a point I want to return to at the end. So what about the concepts here? What about integrating this new data into the guidelines? And I don't think it's just new data. I really think it's revolutionary data. Let's step back and say, for a very long time, decades, we've operated around the simple assumption that diabetes increases cardiovascular risk, improving diabetes should improve outcome. And that has been unattainable in the kind of data that you just saw. It is dramatic and impressive and important to wrestle with those new concepts. But it raises other conceptual issues around this, given what we know to be the prevalence of ASCVD in diabetes. And there is no escaping, looking at the current data, that these 2 drugs we're talking about, EMPA and LIRA as initial examples to this class, are underutilized. Despite the evidence you saw, these drugs are underutilized. And of course, that is influenced by the vast majority of people with diabetes are being treated by internists. But that comes down to better job at education and perhaps clear guidelines around how to approach this issue. There's also a very important issue, I believe, around ASCVD and the distinction between known versus undiagnosed. And we've already been through that in cardiology. We've abandoned the idea of a central tenet being, if you survive your heart attack, I'm going to get really aggressive about your LDL lowering. We now calculate risk for an event and base it upon risk and even patient risk groups, as opposed to asking someone to have survived an event to say that now you're going to get aggressive, because that's not the nature of the disease process. And so to what extent would cardiologists advise internists and endocrinologists of the extent to which they think their patient has a high degree of risk and has undiagnosed atherosclerotic cardiovascular disease that warrants thinking about better ways to manage that, rather than asking them to survive an event, and then we're going to get serious about their treatment. And we know, and we have data as many other groups, this other very large category, type 2 diabetes, whether it's unknown, known, or undiagnosed, which we know is highly prevalent. And the reason why I highlighted this in yellow is back to the idea of cardiologists. Most of you practicing as cardiologists, whether nurse practitioner or physician, are not seeing as many patients without a history of ASCVD. That's just a fact. You are seeing many, many patients who have undiagnosed diabetes. And this data begins to change that approach to say, I'm not going to let undiagnosed diabetes through my practice and through my hands, because there's something I can do that's going to change the outcome that I'm responsible for. And so I think this is a new concept that has to begin arising and trickling into guidelines. Cost does matter. Here we have significant cardiovascular benefit, and I do think that the cost is justified, and we're going to see more and more economic analyses about the money saved and the economic impact, but certainly can't be dismissed, and I think that will translate and should translate into more intensified and clear guideline language. And the class issue, I think, is very relevant. So we had Dr. Pfeffer review the LIXA data, maybe the difference in trials. There's also a question about mechanisms of the drugs, longer-acting GLP-1s versus shorter-acting. Is that part of it? We have to explore that and know that, and we're waiting for data around CANA and DAPA. But we have to have caution until we have that data, because there can be differences very relevant to what Dr. Bremer reviewed about ROSI versus PIO, and some differences there, for example, with lipids, and does that translate into events? So something we'll keep referring to. I think this relates to another conceptual point I want to raise, that in 2017 we need faster guideline updates. It can't be the sense that this is scripture and that people are going to need to retreat for a year or two before they provide something that's going to be chiseled into stone, and there's concerns about writing in the stone. With good, solid data where experts would agree, I think we have to look to quicker updates because of this impact on physicians and on payers across the spectrum of healthcare. I want to return to this issue about cardiologists specifically, because when we talk about translating clinical trial data into clinical practice and guidelines, I think one of the questions is whose guidelines and whose practice are we talking about? And for cardiologists, this is not news. Here's from Jack in 2000, Diabetes and the Cardiologist, a call to action. On the left is additional emphasis by the American College of Cardiology on diabetes. As a matter of fact, every ACC chapter held a program around diabetes to try and get cardiologists to begin dealing with the issue and being willing to treat. But we just saw 50% of the folks in this room have not written a prescription in the last month. So what are those issues? Well, we highlighted in the question, there's concerns about follow-up, about patient teaching, especially if you're going to talk about an injectable like GLP-1. In our practice, there would not be someone who would allow me to initiate that, because I wouldn't have someone who'd be able to teach that. Lack of experience in terms of some real-world issues like, well, how much does it cost? Can I do the prior authorization? Can I handle those issues? How am I going to deal with the side effects? Am I familiar with them? And what to warn a patient about, this turf sensitivity I mentioned. And I just want to point out that these can all be dealt with. We're very interested in trying to pursue programmatically how you share resources. across two divisions by sharing certified diabetes educators. Certainly we can learn how to teach patients, have people in the clinic who can do that. We can learn about what the various issues are. Many of the risk issues, I think, are arguably even safer with some of these agents. And I would say, because there's a very high percentage there on why someone may not be using it, is because they don't want to step on toes. I've never, ever had anyone feel like I stepped on their toes, either by more aggressively managing lipids or by initiating or titrating anti-diabetic medications. The response is usually thank you, because most internists are way too busy, and I have not had any response. And as we've looked into that from a data perspective, there's very little evidence that someone's going to be upset that you took this on, and certainly there's other strategies for that. And here's the other thing, as we went through this and looked quite a bit at this issue of why weren't cardiologists doing more around treating diabetes, here's the big answer. For decades. Why bother? Because it was not going to change events, and that's not true anymore. It's simply not true anymore. We have outcome data. We have data that requires cardiovascular expertise to be involved in and help interpret for our endocrinology colleagues. I actually have concerns about the ball here falling between the two outfielders, where the endocrinologist says that's a cardiology drug. It has cardiovascular benefit. I'm just not going to get into that. And the cardiologist is going to say that's a diabetes drug. I'm not going to get into that. And that's when the ball lands between right field and center field. And the reason why we have to do it, because it's better patient care that's involved there. So in terms of those translations, there's a few points that I would make in conclusion. I think we need to have guidelines from the ACC, AHA, from our professional groups around this. Not because we need another set of guidelines. It is absolutely not for reassessing management algorithms. It's for true translation, as in cultural and language issues around how the cardiologist should approach these issues in terms of choosing an agent, the contraindications, the side effects, and very clear directed language for the cardiologist, from cardiologists and endocrinologists, as part of that advice that I think could be very helpful and quite important. Not unlike what the ESC has done about integrating that data, but very focused on the pragmatic aspects that can make a cardiologist feel comfortable in using these drugs. Here, as you see from the Canadian guidelines, a table that highlights on the hypoglycemia issues, the rarity of those events for the two agents we're talking about. But this is in a table in the back, and I can almost guarantee that no cardiologist is reading that table. So there needs to be a better translation of this for a cardiologist who wants to know top-line approaches. A second step is that idea of diagnosing diabetes in your practice. Very easy to check an A1C level as one way to have some idea, and it is quite stunning if you do that regularly as a cardiologist. Meet a patient with an NSTEMI whose triglycerides are high, you check an A1C, you'll be amazed how often you go, oh, guess what? A1C is 7, A1C is 7.5, or that the patient has prediabetes, another interesting issue. Another important approach to this for the cardiologist taking on this issue, part of this new world, is raising diabetic therapeutic options in your clinical correspondence. So you don't feel comfortable starting the medication, but it's very impactful for you to, when you write to that referring internist, to say, and I wonder, given his current issues about the use of an SGLT2 inhibitor or GLP-1 agonist for cardiovascular benefits, because we just finished putting in our third stent in this patient, and perhaps that would be an option. And then the other ones is the partnership with internists and endocrinologists. One approach that we've seen some groups doing is to embed an internist endocrinologist within their practice. We have one who sits with us in our clinic. Next to me, as I'm in the lipid clinic, I have an endocrinologist I can ask questions to help with titration, initiation, and sharing of follow-up resources. I'm going to end with that, and then I think we have a chance here for some time with our panelists for further discussions. Thank you.